Parkinson in 1817. It was described as the shaking palsy after he observed few patients who have the disorder. It was further characterized by Jim Martin Charcot. So it results from loss of dopaminergic neuron in the substantia nigra pars compacta, and then this results in reduced striatal dopamine, and then there is also presence of Lewy bodies which contain the protein alpha-synuclein. And then it may also affect the cholinergic neurons of the nucleus basalis of myonets, and then also cause affectation of the norepinephrine neuron of locus coeruleus. So and as well as the serotonergic neurons. So, and it can affect the neurons of the olfactory system. So this image just shows us the substantia nigra in a patient with a normal brain and in the patient who have been affected by the Parkinson's disease. We can appreciate the dark pigmentation in the substantia nigra in the normal brain, whereas in the Parkinson's disease patient, we can see that pigmentation is lost. And usually, by the time most patients present with the motor symptoms, about 60 to 80% of the dopaminergic neurons are lost at that time. So talking about the disease burden, usually Parkinson's disease is recognized as one of the most common neurologic disorders. It affects about 1 to 2% of individuals who are older than 60 years of age, and then up to 4% of individuals who are older than 80 years of age. The disease has doubled in the last 25 years, with global estimates in 2019 showing over 8.5 million individuals living with the Parkinson's disease. And then according to the WHO, the Parkinson's disease has resulted in 5.8 million disability adjusted life years, with an increase of 81% since 2000, and has caused about 329 deaths, which has been an increase of over 100% since year 2000. In a study done in Nigeria, here we have the Nigerian Parkinson's Disease Registry. So this was, as at July 2019, the registry has captured about 576 participants from 5 to 6 different geopolitical zones in Nigeria. And then with about 72% of the individuals captured being male, we have a mean age of onset of about 60.3 years, plus or minus 10 years. And then we have a median disease duration of about 36 months. And then individuals who develop young onset Parkinson's disease, that's the individuals who develop Parkinson's disease before the age of 50 years, they were about 15% that were captured in the data. And then we have a positive family history in about 4.5 to 7.8%. And then usually they have age of onset less than 50 years old. And then some of them have greater than 50 years old. Then continuing with the disease burden. So the crude estimate of the prevalence of Parkinson's disease in Nigeria was said to be lower when compared to the estimates in Europe. So in Nigeria and sub-Saharan Africa, so we have a crude estimates of about 10 to, sorry, the slide is not moving. Can you move the slides? So we have a crude estimate of about 10 to 29, 249 per 100,000. While in Europe, there is about 65.6 to about 12,500 per 100,000 population. So the reason for this is because of poor data management, and then we have not really been keeping data, and then this can also be due to the underdiagnosis or misdiagnosis of Parkinson's disease, because we have other things that can present with Parkinsonism, and then sometimes they are misdiagnosed, and then sometimes the patients themselves may not present to the health facility to get checked. And then also because of lack of experts too, because in the low and medium income countries, it has been found that just about 0.03 neurologists are present per 100,000 population. So because of this, there is also the chances of underdiagnosis. So because the people who encounter these patients, they may not be fully aware of Parkinson's disease, and they may not really get the patients to be diagnosed. And we know that diagnosis is purely majorly clinical. So if we don't have experts that are making the diagnosis, so the disease burden will remain low. The incidence and prevalence of Parkinson's disease increases with age, with the average age of onset being 60 years old. And then the disease is 1.5 times more common in men when compared to women. As a way of etiology, the majority of cases, about 85 to 90% of cases, are sporadic, so the cause is unknown. However, it is said to be an interplay between genetic factors and then environmental risk factors. So we have both genetic factor, and then there's a trigger by the environmental risk factors due to exposures. So genetic risk factors accounts for about 10 to 15% of cases. And then several genes have been located, including the GBA1 gene, the LRRK2 gene, and PINK1 gene. So, and then recently, the GBA1 gene variant was identified in the people of African ancestry, and it's been shown to result in early onset Parkinson's disease, and is more specific for, and it was found by in our environment here during a study involving individuals of our environment. Then furthermore, there are other factors that have been identified, environmental factors, though there is no specific environmental factor that has been shown to cause Parkinson's disease. However, they have been seen in association with Parkinson's disease. This include exposure to pesticides and herbicides, then consumption of well water, living in rural areas. This is also due to the farming and exposure to pesticide, and then consumption of well water. Then proximity to industrial plants and quarries. This is also due to exposure to heavy metals as a result of the quarries and plants. So there have also been some factors that have been shown to be protective. This includes high intake of caffeine, smoking, intake of non-steroidal anti-inflammatory agents, and then calcium channels blocker. However, there haven't been studies to confirm this, however, and then some other studies have also been shown to negate these findings. But these are things that have been seen. Then clinical presentation of Parkinson's disease, like I mentioned, they are purely clinical, diagnosis is purely clinical. So there are typical things that we need to identify. First is the common presentation that people present with is tremors. So usually the tremors are rest tremors. They are often unilateral, and with disease progression, they can become bilateral, but it's persistently more on the initially affected side. Then there is also the bradykinesia or slowness. So there is this slowness in doing things, movements that comes with it. Then rigidity. So there's this stiffness that the patients experience. Then postural instability. This is the late onset symptoms. So whenever it presents early, we need to think about an alternative diagnosis. Then in terms of non-motor symptoms. So most patients, when they present, they focus more on the motor symptoms. However, the non-motor symptoms, they are known to predate the motor symptoms. And then they can be, when they are identified early, they can also help with patients' management. So early in the presentation, patients have hyposmia or anosmia. This can predate the development of motor symptoms by up to 10 years. And then following that, we can have constipation, so they can have the GI, so they will have difficulty moving well. And other things include sleep disorders. Sleep disorders can include insomnia. Then they can have the REM sleep behavioral disorder, in which they will be acting out the dreams. And then there can also be restless leg syndrome being present in them. So in which they'll be having difficulty keeping the legs still. Then other things include mood disorder, and then top on the list is depression. So they can have lots of interest in previously interesting activities, and then they will have low mood. Then they can also have anxiety as well. So there is also presence of apathy. So apathy is usually challenging to both the patient and the caregiver, because the patient will seem uninterested in any activity. However, it's not because of their own loss of interest, but because of the underlying Parkinson's disease. Then excessive salivation and drooling of saliva can also occur. Then cognitive impairment. Cognitive impairment is usually um, it occurs in the late stage of the disease, including the dementia that occurs late in the disease. However, other things that can occur include the forgetfulness. They can be early, then mental slowing that can also come with the disease. Then sorry, I'm gonna go to the next slide. Then the other thing we should note that there are some autonomic features that also come in along with these non-motor symptoms, which include the postural orthostatic hypotension. They can have their BP can be low whenever they try to get up, and then this, especially in patients who are hypertensive and on BP medications, these symptoms can be worse when they take their medications. So they'll need to be monitored closely. As we mentioned earlier, constipation, there can be difficulty swallowing, dysphagia. So, and then this can result in aspiration. This also usually presents late in the disease. There can be urinary retention, um, urinary frequency, urinary symptoms that come up with the disease. Then there can be erectile dysfunction as well. So sexual dysfunction in females and then erectile dysfunction in male being present. Then the next slide just talks about the progression of the disease. Like we said, the non-motor symptoms usually predates the motor symptoms. So usually the hyposmia or anosmia, the anxiety or depression, constipation, and then acting out of their dreams, they usually predict. Then excessive daytime sleepiness can also predict. Then later, they can have fatigue, pain, which are also important non-motor symptoms. Then most of these symptoms will be improves with exercise. That's part of why exercise is important. And then we'll also see that later. Then as the disease progresses, then they develop the motor symptoms with bradykinesia, then the rigidity and tremors. Then with as the further progression of the disease, then they can have the postural instability and the gait impairment. Then the dementia also comes in. Then the next image also tries to highlight the progression of the disease. So this is the staging model that talks about the Parkinson's disease. We have the 1 year staging. So early in the staging, we have the unilateral disease, presence of unilateral tremor. Then later it involves the axial. There's axial involvement. Then it progresses to become bilateral, and then progresses to loss of balance, and then severe disability, and then the patient will become wheelchair bound. So the diagnosis is mainly clinical. So usually because of mainly clinical diagnosis, most of the time, sometimes some patients can be missed, and then some patients can be misdiagnosed. So there are several criteria that have been developed first by the UK Parkinson's Disease Society Bank, Brain Bank diagnostic criteria. Then we have the MDS criteria as well. So I just highlighting the UK Parkinson's Disease Society Brain Bank diagnostic criteria. Yeah. So the first major thing is the presence of bradykinesia. So and then with bradykinesia, then there is also supportive presence of at least either module rigidity or the rest tremors or the postural instability, which is not as a result of either the primary visual dysfunction, vestibular dysfunction, or cerebellar dysfunction. Then there are some things that we need to exclude, which include the presence of a previous stroke. So when a previous stroke is present, it's telling you that the Parkinsonism the patient has is not really idiopathic. Then we have the presence of previous head injury, presence of definite encephalitis in the past, then presence of any neuroleptic treatments at onset of symptoms, then presence of any supranuclear gas palsy or cerebellar signs. So they point towards an alternative diagnosis. Then things that support the diagnosis. We can move the slide down. We can go down with the slide. Hello, am I audible?
Yes, you are. I'm changing the slides.
Okay. All right. So things that support the diagnosis include presence of unilateral onset of symptoms, breast tremors being present. There's the progressive nature of the disease, persistent asymmetry. That's the despite the progression of the disease, the initial side is more affected than the other side. Then the excellent response to levodopa, and then presence of levodopa-induced chorea, and then clinical course of disease more than 10 years or more. So I know the another speaker will be speaking on the management. So I'll just run through some of the management that we do. This include use of, it can be pharmacological or non-pharmacological. For pharmacological, you have the use of levodopa, which is a very important medication because it's the major medication we have available in our environment. So it helps in replacement of the dopamine. So it's a combination of the dopamine and then the carbidopa. Then we have the dopamine receptor agonist, D1 and D2 agonists. We have several of them available. Then we have the monoamine oxidase B inhibitors, the selegianin, then the catechol O methyltransferase inhibitors, so as the entacapone, and then the amantadine. Then we have anticholinergic medications. There are also options for surgical intervention. This includes the deep brain stimulation. There is not currently available in our environment, but you can access it outside the country. Then can have the MRI guided focus ultrasound, which can also be used targeting some sites to help improve motor symptoms. Then non-pharmacologic management. This includes management of the gait dysfunction, management of the constipation, management of the REM behavioral sleep disorder. So first of all, for the gait dysfunction, usually the patients can use some walkers or cane to prevent them from falling. For freezing gaits, they can use some sensory cues such as marching in a place, singing a song, or stepping over a imaginary line. Then exercise cannot be overemphasized in the management of non-pharmacologic management of Parkinson's disease, as it has been shown to help in maintaining and even to improve functions, and also whether both motor and non-motor symptoms have been shown to improve with exercise. So thank you. I'll just leave the floor open for my colleague, Dr. Olaoye, to make some inputs before we move to the next speaker. Thank you. Please kindly unmute Dr. Olaoye to make some comments.
Okay, thank you very much. Thank you very much, Dr. Odeji. I would love to appreciate the Adewunmi Desalu Foundation for this opportunity, and my teacher, Professor Ogun, for giving us the opportunity to represent him in this very important meeting. Now, I'll just, within 2 to 3 minutes, give highlights of what my colleague has talked about, so to refresh our memory. So first, he talked about it being a progressive neurodegenerative disorder, meaning even despite treatment, the disease will continue to progress, and our treatment is to slow down the clinical progression of disease. And this is very important because we need to prepare the mind of the patient and the caregivers. Not give them hope, but not overtly unrealistic hope, so that they won't be depressed or frustrated when this disease continues to progress. And they talked about the different pathophysiology mechanism, which I know our other speaker will talk about, the area affected. substantia nigra pars compacta and what is really happening there, and being a place to coordinate movement. The movement of the patient slows down significantly. He also talked about a lot of data, which I would not want to bore us with, but that the disease is present in our environment, but is underreported and underdiagnosed. And even when it is reported, the hospitals are without neurologists, and they may not pick the diagnosis because there are so many causes of tremor. And in our environment, when an elderly has tremor or some symptoms, is being said to be a disease of the elderly. So some people will not even report it. So it is very, but the data is very low, largely because it's underreported. And also when it is presented to the hospital, it may not be picked up, because of the low number of neurologists we have in Nigeria. Then he also talked about it being largely sporadic, although he talked about some environmental factors that can be a cause of the disease. And on a lighter note, small research has shown that smoking and coffee can have comparative advantage. But should we, because of prevention of Parkinson, now have so many myriads of adverse effects of smoking, So, and so many other studies have disproved, this. So he talked about the non-motor coming before the motor symptoms. Anosmia, that's inability to smell. REM sleep disorder, we know that when we sleep and during REM sleep, we dream. And nature has so made it very beautiful that to prevent us from harming ourselves, we are kind of paralyzed during that sleep. So these people will lack that physiologic advantageous paralysis, meaning while dreaming, if they are playing ball, they can kick the bed, have fractures, and wound themselves. And these are early presentations. Constipation, cognitive impairments, maybe not the frank dementia, which is late, being some of the non-motor. And for the motor, he outlined some, including bradykinesia, rigidity, and tremor, which our other speaker will also talk about. So he talked about the staging. And this staging, the countries where they are coming from, is despite treatment, the disease continues, to progress. He also talked about some of the differential things that look like Parkinson's, but are not. Anytime you see early onset memory issue, falls, and some other presentations, which is likely not to be Parkinson's. Then he talked about the new thing, deep brain stimulation, which if we brought to Nigeria, many of our patients, it's not a cure, but it's also is like a miraculous improvement of the tremor of Parkinson. So once again, I want to appreciate all and sundry for this important meeting. Thank you.
Thank you very much, Dr. Awodeji and Dr. Olaoye, for your presentation. We appreciate you, and we also appreciate Prof for giving you the privilege to provide us with this information. Please, participant, I hope you are following along. If you have any questions, please, can you just drop them on the chat? We'll pick up the questions during the question and answer time. And our doctors are still around. And like I said, Prof is in the meeting, but is not active, but I believe he would be able to provide answers to some of the questions if you put them on the chat. Thank you very much. Our next speaker, please. I know we are relaxed, so I want us to be active. I will be having Josie present her slide in a couple of seconds. But I want you to just pay attention and please don't try as much as possible to be put reactions when some of the things resonate with you. Some of the things that the speakers are saying resonate with you. So we want you to participate in this webinar also. Not necessarily unmuting yourself, but also, put some form of reactions. Thank you very much. Can we bring up since Josie's slide? Thank you very much. So I'll just say a brief thing about our speaker, who happens to be somebody that has been diagnosed with Parkinson's. This is Josie. She is a young onset Parkinson's warrior, and she's currently working with the NHS in the United Kingdom. So she has experience in taking care of people and experience with Parkinson's. So I wouldn't waste time with the profile, because I want her to get on it. So let's welcome her as she give us the information about young onset Parkinson, most especially women living with Parkinson's, the challenges they face, and how to navigate life. Thank you very much. Can we just put our reaction, because it's not easy? Please put reactions. Please, I would like us to put our reactions. Thank you. Ceci? Can you help me unmute her? Or please, can you unmute yourself and Stacey, are you on the call? Can you please unmute and proceed with the slide, with the presentation? Okay.
Yes, now I unmuted. Okay. Good afternoon, everyone. Thank you so much for giving me this opportunity to be with you, especially on this special day, April 11th, the World Parkinson's Day. I'm so grateful for this. Can we have the next slide, please? Okay, so my name is Tinsy. I'm a nurse working in NHS, and so it's a privilege for me to share this presentation with you all. And as today is the World Parkinson's Day, if there is people with the Parkinson's listening to this, or carers listening to this, I just wanted to say that we all are in this together, and even if we are in different part of the world, we are in this together, and we support each other. So let's move forward, and let's all hope for a cure. So tulip is the symbol of Parkinson's, so that's why all the slides are filled with the tulips, and let's hope we can find a cure in the future. Can we have the next slide, please? So a Swedish psychologist, Carl Jung, says, life really does begin at 40. Up until then, you are just doing research. But in my case, I started my research after 40. And also, Linda Poindexter says, one small crack does not mean that you are broken. It means that you are put to the test and you didn't fall apart. So these both quotes are really applicable in my life, because as I said, my research started after 40 because I have been diagnosed with Parkinson's at the age of 41. And yes, that crack, there was a big crack, but I didn't stop there. I moved forward, and because of that journey, because of only that journey, I am here with you today. So can we have the next slide, please? So I will just share quickly the diagnosis journey. So I was over 20 years working as a nurse at this time. And this 2025 is my 25th year as a nurse. So in 2019, until that time, I never ever imagined or thought about like being a nurse and then once become a patient taking bundles of medication. But all of a sudden, the life has changed. My perception about the life has changed. So in June 7th of 2019 is the first time I have been to the GP for this problem. And it was an unusual symptom I felt. Uh, while I am walking in the hospital corridor, I felt like my right foot is making louder noise while walking. Felt like I am stamping on the floor. So initially I thought if I go to the doctors, being a nurse, what would I say? And then what they will think, am I being silly? So first I ignored, and then I later on, a couple of times when again I felt this, I thought, okay, when I have the next time off, I will go for this to the GP. But then one night, one of my colleague noticed the same problem, and then she told me to go to the GP and check it over. So I have been to the GP, then GP sent me to the hospital because they knew that there is something neurologically wrong. And initial investigations carried out, and all the results came back as normal. Then I have been referred to the neurologist. So I have been seen by neurologist in 2019 July. And while waiting for the neurologist, I was asked to take off sick, and I was resting at home. Meanwhile, I could feel like I have experiencing resting tremor and also stiffness on my shoulder, which I had before. And I was thinking I am getting old, and because of that, I am getting these symptoms. But then when after the several examinations, the neurologist asked me to draw on a paper, asked me to write. Then I realized how my handwriting has changed. And also, he asked me to walk several times in the corridor. And then when I finished walking, he said, when you are walking, your right arm is not swinging as much as your left arm. So all those things are, I was noticing like very new. And then he suggested it could be Parkinson's, but he wanted to exclude any other problems. So he said he wanted to do further investigations. That's why I had in September 2019, I had the DAT scan. And so on September 25th, I received the diagnosis as it's early onset moderate Parkinson's disease. So I received my diagnosis while I was at work, and it was, even though I was expecting this, it was really a shock for me, and my mind and my heart, brain, everything went blank. I was in a dilemma what to do. And then when I put the phone down, God sent my matron in front of me. So I told her, I want to talk to you. So she take me to her office. I burst out in tears. And then she gave me time and space to calm down. And then the next few, for around 5 to 10 minutes, she spent time with me. And then um, uh, she has given some really positive support for me. And then she said, we all are here to support you. You can continue your career. You can progress in your career. There won't be any issue for that. And so that support was, it was very, very helpful for me. And uh, that moment, I felt like I am in the right place at that time. And then that helped me to move forward. So being a nurse, I know what to expect. And being a nurse, I have seen several patients with advanced stage of Parkinson's disease. So it was not easy to get into it's not easy to accept and then move forward. But, as a nurse, as a mother of two young children, as a wife, I have to move forward because I have to move forward and look after my family as well. So believe in God, and with the prayers and support, I am moving forward still. So, the same way, I just informed some of my senior colleagues because they are supporting me at work. But yeah, it was not easy for me to share with other people. So I kept it quiet, and then uh, after in April 2021, um, on April 8th, I was sitting at home, and then I was thinking, um, I heard about Parkinson's UK. That is the is the main charity supporting people with the Parkinson's and carers in the UK. So I just a thought came into my mind, just check what they are doing for the World Parkinson's Day. So while I was going through the Parkinson's UK website, suddenly I came across with a video, Get It on Time. So I just thought, what is it? Let me open it. So that video was showing the importance of giving Parkinson's medication on time. And then when I read further, it was saying about people admitted in the hospital is not getting the medication on time. That is causing problem. And so when I watched that video, that opened my eyes. And that is the moment I realized there is a purpose behind my diagnosis. And as being a nurse, I should not hide my diagnosis and sit back. There is a job for me to do. So that moment, I decided to come out of my hibernation, and then decided to move forward further. So on April 11, 2021, I joined uh, Parkinson's UK. And then since then, I started my advocacy, my volunteering, campaigning, and research. So as I am working in the hospital, I have, along with my colleague, I have made a presentation about the importance of giving Parkinson's medication on time, and then given teaching to my colleagues. And also later on, I in Parkinson's UK has a magazine called The Parkinson. You can that's available on online as well. So Parkinson's UK wanted people from ethnic minority background to share the stories. So when I heard that, I was debating in my mind, as a being a ethnic minority person, being a woman, if I share my story, am I be um, should I do it or not? Whether there is what people may think about me, will they exclude me? So such kind of lots of thoughts came into my mind, debate quite a lot. Then I spoke with my husband. He agreed for me to move forward. So I shared my story in the magazine, and then that helped me to find a support group that is called NHS Professionals Living and Working with the Parkinson's. So that in that group, all sorts of professionals are in that group, all over the from all over the UK. And so it is a very supportive group, and then it's a safe space for me to share, for all of us to share, because we are not, sometimes it is not possible to share everything with the family, isn't it? So it's a safe space for us to share, and also support each other. And then from that support group, we have decided to take this Get It On Time campaign, and then we formed a subgroup of that, and then we are doing a campaign to improve this medication problem in the hospital for all over the UK. So now the NHS England has taken over that project, and so we are trying to do good for the Parkinson's community. So this is now I am a registered volunteer and a campaigner for Parkinson's UK, and also I have taken part in research and also promoting research, especially for women and also ethnic minority background people. Can we have the next slide, please? So I don't know whether you people have seen this picture or not. This picture has been released on International Women's Day, March 8, 2025. This is created by Barbara Salzberg Matthews. So she's a woman living with the Parkinson's in Canada. She's an artist. And so in this picture, what she's trying to illustrate is women with the Parkinson's, 5 stages of Parkinson's, whichever race, whatever color they are, all the stages are the same. So these are the two pictures I have put here, but John has the link. He will put it in the chat. It shows all. There is more pictures, like even the white people. Also, it's the same stage. So, but the message is like women are also affected with the Parkinson's. It is, and also it is more women are getting affected. But there is not much difference between men and women. The statistics shows like around 40% women are diagnosed with the Parkinson's, and also there is more research needs to be done for the women, because there is studies shows that during the menstruation, during the pregnancy, the hormonal change, it affects the symptoms of the Parkinson's in women. So, and also these timings, the medication efficacy can also be changed. So there is lots of research needs to be done to prove this. So that's why women need to come forward to take part in research and also support each other, because if there is no enough support, it may not be enough for everyone to get more involvement. Can we have the next slide, please? So challenges of the living with the Parkinson, it's a big challenge, and there is lots of challenge, like there is a motor and non-motor challenge, and also sharing the diagnosis to yeah, that is a big challenge, especially sharing with the children. That is the big problem I have faced. And also complex medication regime, because at the beginning you might be on only 1 or 2 medication, but as the disease progresses, there is different medications you have to take. And then when you are living with early onset Parkinson's, you are working, and then your employment is a big challenge, then the social connections, and there is different challenges for the women, because women is acting on different role, because she's a mother, she's a wife, and she's a sister, and also she is working. So there is lots of roles women is handling, and also she is handling this non-curable condition. So that is a big challenge for a woman, and also emotional challenges. And the hormonal change also is a big challenge for a women. But what need to think is, being challenged in life is inevitable, but being defeated is your option. But you should not try to defeat yourself. You need to move forward. So can we have the next slide, please? So how can we navigate these challenges? When you receive the diagnosis, take time and accept the diagnosis, because as I mentioned, it's not very easy to accept it, but take time, and then when you are ready, then only you share with everyone, because when you share with, you will be facing lots of questions and things like that. So you make up your mind. When you are ready, you share with whoever you wanted to share. And also, but you have to have an open and honest conversation with your family, because they are the one going to be there for you 24/7, and they are the one going to be travel with you all through your life. So, and then build the resilience and also focus what you can control, because sitting and being anxious about tomorrow what is going to be for me, that is not good for you. So, and also you need to seek help, and then also understand the lived experiences of the people, and read other people's story, listen to that, and also be a part of positive network. So that will help you to navigate. Can we have the next slide, please? And to move forward, you need to embrace strength. So you accept it, and then you develop resilience, and then also you need to talk to yourself. Positive affirmations will help you, and also you need to love yourself, and then find your values, and then grow in that one. Leave away all the negativity, and then utilize your strength, because if you are living in the negativity, you won't be able to move forward. And then utilize your strength, maybe supporting just one person could be the initial part, and then if you can grow from there, and then you get feedback from the people what you are doing, and then when there is success, celebrate that and share that. Then you go back and review that. That will help you to move forward. Can we have the next slide, please? And as a person living with Parkinson's, we always need to enhance our quality of life. So you need to be independent. So because the Parkinson's disease will affect your motor abilities. So always try to be independent. And then the medications are, doctor already mentioned about the medication. So these medications are lifeline for you, and then you need to take that medication on time, because even 30 minutes delay will affect the problem, affect the symptoms, because these medications are controlling your symptoms. So the symptoms will come back if there is delay in medication, taking medication. And same way, exercise is also very important. So doing exercise at least 2.5 hours in a week will help you with physically, mentally as well. And also these exercises will help to produce more nerve fibers, and so that will help to produce more dopamine. So dopamine effect will help you to move forward as well. So exercise should be an integral part. As John mentioned, your foundation has lots of active exercise. So be part of that. Then with a proper balanced diet, and then at least 8 hours of sleep is mandatory, because if you are not sleeping well, the amyloid deposit will be more, and then that will cause you during daytime sleepiness and things like that. Then stress is a big part. We know we all going through that, but we need to try to alleviate the stress. Do mindfulness exercise. Then if you are not able to get help, don't sit and worry about, and also be part of support group. And then also being part of a research is very important, because still over 200 of years is not able to find a cure. So we have to try to find, if you are taking part in research, you may not be able to get a cure, but that will help the future generation. So we have to think about that as well. Can we have the next slide, please? Parkinson's changed my life, and I was not a person pre-diagnosis. If the pre-diagnosis Tinsy won't sit here and talk to you, that was a different person. So after my diagnosis, I came across that I am able to write poems. So this is a part I have taken from my poem. To live well with Parkinson, you have to be a Parkinson. So positivity help you to go forward. Active nature improves your movements. Resilience helps to face your challenges. Kind to yourself is key to care for own health. Insightful thinking is a powerful to be purposeful. Nurturing skill will help to support others. Self-confidence is mandatory uh, to carry on. Optimism will help you uh, to achieve dreams, and noble attitude leads you to positive outcome. Can we have the next slide, please? So Parkinson's may challenge the body, but it can never touch the spirit. That remains resilience and determined. So uh, so sorry, I have taken a few extra minutes, but thank you for giving me the opportunity to share my experience and my life. I wish you all a good day. Thank you.
Thank you so very much, Sensei Jose. Please, can we get reactions? Can we get reactions? Please use the reaction buttons, please. Thank you very much. Wonderful slide, well crafted, and easy to read, easy to digest. Really appreciate you for this. Please, we have people with Parkinson's here. We have caregivers here. If you have questions, kindly put them on the chat. I can see some of the questions rolling in. We're not going to take much of your time. Try as much as possible to accommodate all the questions as we have the time to spend in the webinar. So our next guest speaker is Dr. Aminat Bakari. Dr. Aminat Bakari is also a distinguished consultant physician. She's a neurologist with over 17 years of clinical experience, and she's specialized in comprehensive neurological care. She's currently heading the neurology division of the Federal Medical Center, Abeokuta, and she's the CEO of Tanimap Healthcare. Please, can we make welcome Dr. Aminat Bakari. Thank you very much for honoring our invitation. Let's have you. Sorry, please, before you come on, we've been sitting for quite some time. Can we just have some few stretches? If you can put on your camera, just put on your camera for 10 to 15 seconds, please. Just stretch your hand. We have people with Parkinson's on the call. Stretch your head, stretch your body, move your, just, it's a Parkinson's thing, and we don't want to just sit in a particular position for so long. We want to stretch our body. Please, you can turn on your camera, please. Turn on your cameras. Turn on your cameras. Just stretch your body. Okay. I think we're good. So let's have you, Dr. Aminat Bakari. Hello, Dr. Bakari.
Yeah, good afternoon.
Okay,
Good afternoon, everyone. Hope I'm audible.
Yes, you are. And if you don't mind, we'd like to see your face.
It's fine. It's just because of the bandwidth of the network around here. So I wouldn't want it to affect the maybe after the discussion.
All right.
Like to do that.
Thank you.
Thank you very much. Good afternoon once again. I'm Dr. Bakari Aminat, and thanks for having me. And thank you, Adewunmi Desalu Foundation, for giving the opportunity for this talk. And I want to appreciate my boss, Professor Yomi, for giving the opportunity to be here with us today. Standing on existing protocol, I would like to talk about early detection, diagnosis, and care pathways for Parkinson's disease in Nigeria. So a lot has been said, both by previous speakers And I will not overflog it so that we can have time to discuss and ask questions more. So kindly move to the next slide, please. Thank you. I'll be running through this outline. You can move the slide. Thank you. All right. By way of introduction, Parkinson's disease is a neurological disorder and affects the brain. However, there are so many other multi-systemic symptoms that could come with Parkinson's disease even before diagnosis, which is or which referred to as a non-motor symptoms. As it's been emphasized earlier that most of these symptoms could even be there almost like a decade or more before the obvious symptoms that we characterize as Parkinsonism. And it's like a common, one of the second most common neurodegenerative disease after Alzheimer's disease. Next slide, please. And by way of epidemiology, more than 6 million people are affected worldwide, and the prevalence is a little bit higher in male than female, mostly out of the hormonal differences, protection in females. We have a mean age of onset as 60, but we could have young onset PD as well as 40 years. And these account for just less than 5% of cases, with a crude prevalence of 10 to 249 per 100,000 individuals. The cause of Parkinson's disease is not known. However, there is an interplay between genetics and environmental factors. So much has been said about the genes involved, and which I will not want to overflog that. But age is also a very constant factor that anyone above 60 years is at risk of having Parkinson's disease. So most of the time when there's genetic and environment interplay in people who are exposed to those risk factors that could cause Parkinsonism, presents with Parkinson's disease. And also we have the familial one, which account for like 10 to 15%, aside the most common one, which is referred to as sporadic PD. There are lots of environmental factors that have been picked as a risk factor for Parkinson's disease. Very high on the list are pesticides and herbicide. And if you look at environment here, so many people use this without the necessary protective clothing they are supposed to use. And they do that unknowingly, and after some years, they come down with these symptoms. So, and it's so common around us now that people are going into farming, and that's why you also have PD among a sizable number of farmers. Also, exposure to heavy metals like copper, manganese, and lead. We have a lot of people who work with all these heavy metals, either through industrial exposure, through the environment, or people even residing in area where we have a lot of this deposit, industrial areas could be at risk, as well as organic pollution. There's so many unrestricted use of all these solvents now, and they are thrown into the environment, the air polluted, and that increase the risk of people exposed to it, especially those with those genetic undertones and at risk of having Parkinson's disease. Also, industrial solvents, common is what we call the MPTP. Used to be like a chemical in heroin cracks in those days. You see a lot of people, heroin abusers, tend to come down with this. This was found to be the major component or major chemicals that was found in those psychoactive substances. With all this, the risk factors, the genetics, the familial, the environmental factors put into play together to cause loss of dopamine producing neurons and some other brain damage. These occur through a lot of mechanisms, which one of those things that have been well elucidated is the gut brain axis. Like an alteration in the gut microflora also could have affect people and could make them predisposed to Parkinson's disease. Parkinson's disease is a form of a nucleopathy, and it's as a result of some what we call alpha-synucleins. They are like misfolded proteins that are deposited, it forms clumps, and they are deposited in the cells. This leads to cellular disruption and neuronal damage at the end of the day, which invariably damage the dopamine cells and also deposits in some places in the body. First, one of those things are the olfactory lobe, and that is why loss of smell or reduced sensation of smell is one of the most earliest symptoms in patients with PD. Most of the time, this goes unnoticed. That when they now come down with the symptoms and they present to the hospital and they are being cleared or taken history by the doctors and they are asked about this, most of they now remember, oh, there was a time I noticed that my sense of smell was gone. I couldn't smell anything again. I even thought it was a flu. So most of the time, when you pick a sizable number of Parkinson's disease, people living with Parkinson's disease, they tend to give this history of loss of smell at one point or the other. Also, these synucleins, they are also deposited in the gut, and that's why constipation is also GI symptoms generally. Main one of it is constipation that they present with the prior the symptoms or also alongside the symptoms. So most people that have Parkinson's disease tends to complain of constipation most of the time. It's as a result of this. So over time, we often, like years, 5 years, 10 years, the symptoms of tremors, slowness of movement, rigidity, or some tendency to fall start coming in. And that's why what will bring the attention to it before people present to the hospital. So you could see that a significant number of neuronal cells are gone even before diagnosis. So these other non-motor symptoms, they vary. It's not just only the olfactory system, the sensory system, or it could affect the sleep. The main one is what we call the REM sleep behavioral disorder, in which someone who is at risk of developing Parkinson could have previous history of acting out his or her dreams, or either through or talking from sleep. And sometimes they give you history of like, oh, when I was sleeping, my wife complained that I do hit him. I do hit her, or my spouse always complains that I talk out of my sleep. These are some of the things that could be that is possible in people with Parkinson's disease, and is very, very common in them. But most of the time, at that time, those symptoms are not there. So and there are so other things that could also present with this kind of sleep disorder. So is just increasing the risk. So in an environment whereby there's a family history before, you're now having that allows the person to present early to the hospital and they're able to follow up well, maybe some other things that they need to do while disease progress in terms of lifestyle changes will be done, and this could greatly retard the rate of progression of symptoms. Also, another thing with sleep is they could have insomnia. They won't be able to sleep, either initiating sleep or early morning waking. It could be either of the two. Also, mood disorders like depression, anxiety, all these are so common. And most of the time, because they are lone symptoms, people don't usually put their mind to it. It's only when, in retrospect, when those questions are now being asked, that you now put one or two things together and then realize, actually, this has been with me for some while. Please kindly let me move this slide. All right, just like my first speaker said, diagnosis of Parkinson's disease is clinical, but there are times that patient presents with these symptoms and there are some red flags in it. For instance, someone who's having features of what we call autonomic intolerance, orthostatic intolerance. When they stand up, they feel dizzy, fall, especially when they change position, either moving from sitting to standing or from lying down to sitting. Or history of fall, maybe within 1 or 2 years of history. These are like red flags to know, is this really Parkinson's disease, or things that looks like Parkinson's disease, which is referred to as Parkinson plus. And when they come, we ask history of the tremors, which mostly is at rest. And this kind of tremor, most of the time, it's a pure rolling tremor, and its frequency just about 4 to 6 Hz. And most of the time, when it starts from one side of the body, it's asymmetric. But over time, it could be bilateral. However, it should be noticed that one side will be much more pronounced than the other. Also, rigidity in the body from the limbs, the core, the trunk, the slowness of movement. They realize, oh, I'm not working as fast as I used to be, or their relatives or people around them at the place of work calling their attention to that. You're not working so fast. Is there a problem? So these are things that call the attention to this disease entity before people present to the hospital. Kindly help me move the slide. Thank you. This is a slide trying to show us how it progress. That most of the time the non-motor symptoms comes first, which I mentioned some of them earlier, before we see before we start seeing the tremors, rigidity, and postural instability. And over time, after some years, they start developing cognitive issues like dementia, hallucination, cognitive dysfunction, even sexual dysfunction, which was mentioned earlier. Things like libido, reduced libido, erectile dysfunction, orthostatic hypertension, whereby normally when we stand up, our blood pressure is supposed to be maintained. But in people with Parkinson's disease, their blood pressure falls. So this doesn't allow them to be able to withstand that posture. So most of the time they feel dizzy and sometimes they fall. And that's some of the causes of recurrent falls in them. Kindly help me move the slide. Thank you. Yeah, the care pathways. The care pathways is divided into these 5 components. First is the primary care pathway, the clinical flow, the multidisciplinary support, the care planning, and technology. Yeah, I would like to talk more about the primary care pathway because most of the time, when our client goes to the health center, or some who don't really have access to neurologists, but only to their primary health centers to see their primary care physician. This pathway is good for them so that it will allow good referral and easy access of care by our patients. Kindly help me move this slide so that I can talk more about it. Yeah, but the pathway involves the primary care physician identifying the symptoms early, because not everybody come with the typical symptoms, or not everybody's symptoms is so florid to be noted. So it takes a very astute physician to actually pick those symptoms. They might come because of another thing entirely, but maybe while discussing with the patient, we notice that they're having some tremors in the hand, or while they're walking into the consulting room, we notice, no, this person is having a particular gait that is suggestive of Parkinson's disease. So early identification and assessment. So primary care physician identify them, assess, and know, okay, what is the treatment plan for this particular patient, because we need to individualize their care. And also look out for high-risk features like people who are already progressing into having early dementia, or it's almost at a stage of moderate to advanced stage. And after, they also make sure they get appropriate referral by giving them the connection between neurologists that could take care of them, as well as, while they are doing that, enough education for the patient and the caregivers so that they understand what it is and the modalities of care it entails. And this primary care physician every time collaborates with the neurologist, either physical or through telemedicine, so that patients can always get access to their doctors or a physician that could treat them at any time, even while in their own homes. Telemedicine, virtual consultation could put into play so as to reduce unnecessary hospital visits and also reduce the stress on our patients. Then very important and key is patient family education, because they are the one taking care of our clients. They need they need to understand the chronology of the event and what they need to do and how to support to retard the progression, being a neurodegenerative disease. Kindly help move the slide, please. Yeah, this is like a cartoon trying to tell us different drugs. So management of PD involves both drug and non-drug therapy. So much has been said about levodopa by the first and second speaker. There are a lot of other drugs too that when you get to the doctor, a treatment plan is made and they know which level and what level of care does this patient need. So levodopa has to be started as early as necessary. It is very, very important, as well as the other medication depending on the symptoms the patient is presenting with. Other non-drugs include exercise. Exercise. We can't overemphasize it. Daily exercise of about 30 minutes to 60 minutes, at least 3 to 5 times in a week. This also improves their mobility, reduce progression, as well as their cardiovascular health. Very, very important. And diet rich in vitamins, vitamin C, vitamin E, and that could help as anti-inflammatory. Also, the diet, high fiber diet, helps to reduce or improve the symptoms of constipation, which is one of the major presenting symptoms in patients living with Parkinson's disease. So also exercise, aerobic exercise, physical therapy, balance exercise, resistance training, in which they'll be able to strengthen the muscle, reduce rigidity. Also things like dance and reading classes, cognitive exercise to improve the cognition. Then advanced therapies. Advanced therapies might be necessary in some people who are not doing very well despite maximal tolerable dose of the oral medication. Things like jejunal levodopa infusion, apomorphine pumps, all this can be used. And also in someone who is not improving, the tremors is not improving, as well as the motor symptoms, could do what we call deep brain stimulation. There's some other non-drugs that have been studied and have some benefit, like yoga, massage, meditation exercises. They are very, very good. And this goes a long way to improve the mobility of our patients. Kindly help me move, sir. Yeah, all this, just like I said, most of the time is not just a doctor. We have a lot of other medical practitioners in line, physiotherapists. The speech therapists help them with the speech because they have reduced voice. Most of the time they come with monotonic voice. So help them with the swallowing exercises because some could also present with a difficulty with swallowing. Also, our nurses cannot be overemphasized. They're very, very important. Psychiatrists, psychologists, both for the patient and the family, because it's not easy to take care of someone living with Parkinson's disease. Kindly help move the slide. Care planning, individualized care for the patients, engage everyone, and at the end of the day, it's something worthwhile because patients will appreciate that, and the carers will also appreciate that they are also being involved in the care. Kindly help move the slide. Thank you. Also, things I've mentioned earlier, sometimes our patient don't want to go out, or maybe they have a particular symptom that, or a complaint, they need to get to the doctor and their clinic dates are not there. There are now advances in like different mobile apps, which you can access to see your doctors, your specialists, virtual consultation with both the primary care providers and the neurologists, even some wearables. Then even things to help with tremors, weighted utensils when they're eating, and walking aids. Us trying to make sure the house is stationed or incorporated in such a way that it reduces the risk of fall, and even if there's such, it reduces the trauma that they could that could happen to them. Please kindly help me move. Thank you very much for having me. Yeah, my few references. Good afternoon once again.
Thank you so very much, Dr. Aminat Bakari. It has been a pleasure. Talking about the care pathway, referral pathway is something that I sincerely appreciate because a lot of people identify, but they don't know where to refer to. And walking around every aspect of the care component, we really appreciate that. And thank you so much for being part of this webinar. Right about now, we're going to straight into the question and answer. We have a lot of questions already lined up, and we'll try as much as possible to manage the time so that we can close early. Please, for every question we cannot answer today, we will try as much as possible to answer it during our symposium that is coming up on May 3rd. So if you're in Lagos, you can join us. I'm just making that advertisement ahead of time. But please take note of it. We're going to share the link. You can register. If you're in Lagos, you can come. And if you're not in Lagos, you can also join us virtually. So I'll be asking questions. Please, I hope all the guest presenters are still on the call. So you can unmute yourself once any question is directed to you, so and answer the question. Thank you very much, all our guest speakers. We appreciate your time, and we appreciate the effort in putting together the slides and the presentation. So the first question, you mentioned about pharmacological treatment of PD. What is your opinion on the use of beta blocker like propranolol in the treatment of tremors which manifest in the disease? I think this question is going to Prof. and his representative. What is the use of beta blocker like propranolol in the treatment of tremor which manifests in the disease? Dr. Awodeji, if you are online, please. Oh, Dr. Bakari, if you can answer the question, please go ahead. You can unmute yourself and just...
Okay, thank you very much. To answer the question, this is Dr. Laoye. There are different types of tremors, but looking at the pathophysiology of Parkinson, beta blockers is not part of the treatment. It's good for essential tremor, and some other tremors. But dopamine-based medication, either drugs that will supply dopamine to the site, like Cinemed, levodopa, carbidopa combination, or drugs that will reduce the breakdown of dopamine at the neuronal sites, either MAO or COMS and other ones. So we should, anybody affected should visit, and so that the neurologist can determine the type of tremors, know if it's Parkinson's and address it precisely. Thank you.
Thank you very much, Dr. Thank you very much for that, Dr. Laoye. Another question, can we have more information on young-onset Parkinson? Yes, you can have more information. Our comms officer is going to share more information about young-onset Parkinson's. And if you would like to join our symposium, you will hear more on young-onset Parkinson's. So another question is, does lifestyle changes like exercise, cycling, and football slow down the young-onset Parkinson's progression? I would like Sensei Joseph to answer this question. Thank you very much. Sensei, are you still on the call? Please unmute yourself.
Yeah.
Okay, thank you.
Can you hear me?
Yes, we can hear you.
Okay. Can you repeat the question, please?
Lifestyle changes like cycling and football, can it slow down young onset Parkinson's progression?
Yeah, any type of exercise will slow down the progression. So cycling is very good exercise. And also, I think in Africa you have a walking football team and competitions there, isn't it? Yeah. So
yes.
yeah. So there any form of exercise, doing at least half an hour every day or at least 2.5 hours per week is same like medication. So try it as your part of your everyday job.
Right.
Thank
Thank you
you.
very much. Thank you very much. You've heard it. Exercise half an hour a day, 2.5 hours a week would help. Please, any information, another question, please, any information like development as regards stem cell treatment for PD. Stem cell treatment for PD. Dr. Lauye, Dr. Awodeji, or Dr. Mrs. Aminat Bakare. You can answer the question. You can unmute, please. Any information / development as regards stem cell treatment for Parkinson's disease?
Okay.
Please go ahead. Unmute and
Okay, thank you very much. I was having some challenges on muting. Okay, so there are several new things in the pipeline. There are attempts to transfer functional dopamine producing cell that will act like the normal dopamine production area in the substantia nigra par compacta in the midbrain, so that dopamine can be produced. And there are so many other ones, surgical interventions. We've talked about deep brain stimulation. So out of all this new or novel treatment, the deep brain stimulation is the one that is proven to be effective and is currently available in many of the countries in the world. But for the surgical intervention, pallidotomy, some stem cell transplant, and others is still in the pipeline. And many of them are not available for humans, as we speak. But in the nearby future, probably, like we have in some other diseases like diabetes mellitus, where some beta cells that can produce insulin can be transplanted and produce insulin. Probably in the future, we'll have something like this that will be available for humans to use. Thank you.
thank you very much. Another question, because of our time, I need to rush. PD is treated only when the manifestation is outblown. What are the early biomarkers that could detect this disease earlier? Also, how early should the treatment of PD commence? Is it when the disease is fully outblown? That's the question.
Thank you very much. Just like we said earlier, it's like a continuum. There are some symptoms that are not motor. Patient could present with them. Things like anosmia, REM sleep behavioral disorder, some sleep issues like insomnia, erectile dysfunction, and all sorts. If you have this, we don't start the dopamine therapy because they don't have the full-blown motor symptoms. However, it's been evidence-based that the lifestyle changes goes a long way to help improve and retard the rate of progression. Things like the exercise, we can't overemphasize the exercise and the diet, physical activity, cognitive exercise, and all of that. They are very important. But we start dopamine replacement therapy when people start having the symptoms, and it starts from there. So the kind of drug they will give now depends on, are they having just the symptoms of the dopamine deficiency, or they are also having some other complication as well. So that's the route. But to use dopamine replacement therapy when they don't even have the features of Parkinsonism is not an evidence-based decision. So it's from lifestyle before medication. But most of the time in our environment, it's only if people have family history, they have all these symptoms, and maybe access to genetic evaluation, yeah, they're able to confirm that yes, most likely I'm in a prodrome PD. But most people, they have this in isolation, and it's until those other things like rest tremor, rigidity, and postural instability starts, bradykinesia, that's when they know, yes, I actually have Parkinson's disease. I hope I've answered the question. Thank you.
Thank you very much, Dr. Aminat Bakari. Another question, this is directed to Adewunmi Desalu Parkinson's Foundation. Does the foundation provide financially challenged individuals does the foundation help financially challenged individuals navigate Parkinson's disease investigation by offering referrals to organizations providing financial assistance for medication, transportation, and basic needs, or they also provide information on various government social services program? Additionally, does the foundation community grants foundation fund community grants that supports programs aimed at improving health, wellness, education of people with Parkinson's, potentially impacting accessibility for those facing financial constraints? Wow, this question is loaded. I will answer that, and I'm going to start with the foundation provide care and support, and not necessarily finance, because we are one foundation and we are providing support based on the capacity that we have. Our services is at no cost to the beneficiaries, those with Parkinson's and their caregivers. However, it comes at a cost to some people. So some people are paying for it. So whatever we have capacity to provide is what we provide within the limits that we have as an organization. We're an NGO, we're not a for-profit organization, we're a non-for-profit organization. So presently, we do subsidize transportation for people to visit the center to perform their exercises. We provide medication assistance for people with Parkinson's that fall within the category of most vulnerable. And we ensure that we encourage them in various ways we can to participate in the programs that can help them slow down the progression. However, this has also battered something that I'm thinking about now, which we will discuss internally and see how we can network with other organizations that can provide some form of support based on some of the requests that you have asked. I hope that answers your question. I'll move straight to the next question. Talking about PD management, DBS is a typical management that proves very effective, but very expensive. Is there any less expensive therapeutic measures which could be made available for PD patients in Nigeria that are not financially buoyant? So, Dr. Aminat Bakare or Dr. Awodeji, any alternative to DBS? Hello? Dr. Lawi, please, can you go ahead?
Mute.
Okay, oh.
Hi.
Okay.
Yeah.
Okay.
Thank you very much for the question. DBS is not the first thing to give to a patient on diagnosing Parkinsonism. There are indications for for DBS in treatment of Parkinson's disease. And the person must have been on medication, several classes, different one, depending on the symptoms they're presenting with. Most of the time, if they are not doing well on it, despite being on the necessary dosage and the required medication. So and it's basically for motor symptoms. These help to improve it. So, but DBS now, it's capital intensive and a little pricey. Let's say it's pricey, so it's not something available in it's kind of uncertain. However, before you go to DBS, patient needs to have gone through both the medications and the non-medication care before, and if there are now indications, that's why they go to DBS. Just like my other doctor said, DBS is one of them. There are a lot of other ones, cranial magnetic stimulation, and all of that. It's only DBS that has been found, but it's not everybody that you just give DBS, except there are indications for such. And it's very good, especially when it comes to refractory motor symptoms. So the drug, very important, and the price of the drug varies from one another. But on getting to your doctor, if you have anyone who has such, they'll be able to prescribe what will benefit the patient. And definitely drug medications. I mean, medications are not as pricey as the other advanced care. So I think that's the little I can say for now. I don't know if there's any other contribution from my other speakers. Thank you.
Any other contribution? If not, can I take the next question? How can you encourage the system in Nigeria to motivate more neurologists and train other medical personnel in fighting this life-threatening disease, especially Parkinson's with complication, with a neuropsychiatric disease, which is distressing for patients and caregiver? I'm guessing this is a question from either a caregiver or patient. How do we encourage? So this webinar is part of the ways we encourage people. For some non-medical or non-specialist healthcare workers, one knowledge has been gained today. Some form of knowledge has been gained today. You can't see somebody with Parkinson's without referring the person. At least you've understood ways that you can be able to manage somebody with Parkinson's to help them slow down the progression of the disease. And we're also organizing a symposium that is coming up on May 3rd. You can also be part of it. All of these activities are activities that we put together to encourage healthcare specialists, non-healthcare specialists, stakeholders to improve on health outcomes. If we have more neurologists, we will have more diagnosis. And I believe the gap between the information and the prevalence of Parkinson's is as a result of the limited number of neurologists we have in Nigeria. If we have more neurologists, we will have the exact or the accurate figure for people with Parkinson's. Thank you. Next question. I recently took someone to the GOP presenting with some of the symptoms highlighted today. Sorry, please. Okay. Sorry, my system. Okay. Highlighted today. However, we were not referred to a neurologist yet. Should I be worried? Okay. So either Dr. Bakari or Dr. Aminat, please. Can you, sorry, Dr. Aminat Bakari or Dr. Lawi, please, can you answer that?
Okay. All right. Thank you very much. The question is about someone having some of those symptoms mentioned today, and they are
Yes.
yet to be referred to a neurologist. Am I correct?
Yes, yes.
All right. Thank you very much for the question. When we in a typical hospital setting, we first see a family physician or the primary care provider. They look at this, they look at the symptoms, they evaluate the person, and everybody is trained that at a particular point you need to refer a patient, irrespective of whether it is Parkinson or not. Most likely, the doctor must have his or her reasons, and most of the time, there could be a lot of explanation for that. You might feel the person has Parkinson's disease. Maybe there are other things that are not in line with that diagnosis. So definitely, they'll first evaluate, speak with the specialist neurologist, and at appropriate time, he or she will be referred there. But I could advise the person that when they visit their doctor, our doctors would like to explain to you, and you also have a right to express your consent to your doctors. And definitely, I know for that decision made, they will explain the reason why it was made to you. But I know definitely at the point, they will refer to the neurologist, and it's something you can always discuss with your doctor as well. Thank you.
Thank you very much, Dr. Ms. Bakare. Do we have any other parting words from our guest speakers? We have other questions, but I'm going through the questions. I saw that most of the questions are already have been answered. So if you need further information, you can reach out to us, or better still, join our symposium. That's going to be an in-person / hybrid event. So you have time to ask more questions there. So I would just like to take any parting words from our guest speakers, Dr. Olaoye Tinsi Jose and Dr. Aminat Bakari. Parting words, please. Thank you.
Okay, thank you, Dr. Lauye. I want to appreciate the foundation for this beautiful opportunity to be part of the program, and to our teachers, our chiefs who also participated in this program, and to the audience, I want to say thank you. I believe that by now we have so much knowledge about Parkinson's, and a good referral system will be set up so that our patients can have prompt diagnosis and treatment. And to the caregivers, the more knowledge you have, the less worried or frustrated you become in line of managing your patient. You become calmer if you have more knowledge of Parkinson's disease. Thank you very much.
Thank you very much. Tinsi?
Again, thank you, Foundation and John, for reaching out to me and giving me the opportunity to be here. And I have the message to the Parkinson's patients and the caregivers. You are not alone. When you are struggling, you ask for help, support each other, be in a positive, be positive and optimistic, and support each other, reach out, and and also listen and read for positive stories. So that will help you to empower yourself and then motivate you to move forward. And I appreciate all the work you and John and the foundation doing. I wish all the success, and I wish you could do more in future, and then help Nigeria with the better Parkinson's community. Thank you.
Thank you very much. Thank you. We really appreciate that. Dr. Mrs. Aminat Bakare.
Yeah. Thank you. Thank you, everyone, for having me. And I would like to thank Adewunmi Desalu Foundation for these beautiful programs and activities. And I'm hopeful that a lot of us here today have gained one or thing or the other. So please continue to do the good work. We are rooting for you. I would like to appreciate my prof, Professor Yomi Ogun, for the opportunity to be here today and to learn under him. He's been a great role model and our father. And I really want to appreciate him for neurology service in Nigeria and Africa and beyond, because the neurology paucity in Nigeria, even though for people like him, some of us will not be here. So thank you very much, sir. I want to appreciate people who cares for our patients. I know it's not easy. It's a daunting task, but please continue to carry on. Adewunmi Desalu Foundation is here, and we, the specialists, are here to support you along the way. And I want to appreciate my our patients, people living with Parkinson's disease. You are the real MVP. Thank you very much. Good evening, everyone.
Thank you very much. Thank you very much for that. Without wasting more time, would like to draw the curtain and appreciate everybody for their input. For all the participants, we appreciate you. For all our board members that participated in this event, we really appreciate you. From the chair BOT to every member of staff of the Adewunmi Desalu Parkinson's Foundation, and also people with Parkinson's and their caregivers. We appreciate every healthcare specialist and non-medical specialist that participated and the public that joined today. We appreciate everybody. And like I said, there is still more information to be passed across. So if you care to join us, please don't hesitate to register for our symposium that is coming up on May 3rd. It's going to be a hybrid event. If you want to be in person, please register. And if you want to be a virtual attendee, please also register. We would like to meet you and further discuss this in a broader term. Thank you so much for having us. And we appreciate you on behalf of Adewunmi Desalu Parkinson's Foundation. So see you May 3rd. Thank you.
Thank you, John. Well done.
Thank you, everyone.
Thank you.